Hello and welcome everyone. Today the topic we're going to discuss is a pretty long one, but it's an important concept that all clinicians must understand because Bayesian statistics is one of the important methods by which we do our research analysis. There is a certain amount of uncertainty in our medical practice. Physicians often face significant uncertainties in terms of our diagnosing a particular illness or even predicting outcomes or recommending treatments. These uncertainties can lead to errors if not properly managed. So, how do we manage this uncertainty with probability? Skilled doctors use probabilistic reasoning to handle this uncertainty. They adjust their confidence in a diagnosis or a prognosis based on the available evidence that they have, like the patient's history, the examination, lab results, or the imaging studies. Now, diagnostic investigations as a process gradually reduce the uncertainties by collecting more information. As more tests we do or more imagings we do, we get more information, which reduces our uncertainty regarding a particular disease process. So Bayesian statistics in clinical research is similar to that. It's an approach of similar to how doctors approach their diagnosis. It's an effort to progressively reduce our uncertainty about a particular hypothesis. So research is all about hypothesis testing. So how do we reduce our knowledge about or the uncertainty about a hypothesis is by doing more and more research. So this is the approach of Bayesian statistics. So what do we have right now is called the traditional or the frequentist statistical method. For the most of the 20th century, medical stats has been dominated by this type of statistics. The approach is something which we have already very familiar with, that is p-values, confidence intervals, statistical significance, type 1, type 2 errors, power calculation. These are very common terms for people who are working in medical science. Now, what is the challenge with the frequentist approach? Even though these concepts are commonly taught and used, many people find it very abstract and counterintuitive. Now, few can actually define properly what exactly is a p-value. If you ask any clinician, it will be very difficult for them to define what p-value is. So if I am unable to define something exactly, it will be difficult for me to use it in my practical life. So this is exactly what happens when we see a study. We mostly look at the conclusion. Is the conclusion positive, negative, and if it is statistically significant? But what does that really mean? If the patient asks us, say a particular treatment is good or bad, how good or how bad, how do we answer that based on the frequentist approach? We do find it pretty difficult. That is why clinicians tend to have a separate thinking process for research and separate thinking process while approaching the clinical work or the questions of the relatives. The advantage of Bayesian, though, is that it offers an alternative which is more intuitive and definitely more easier to understand for the clinician as well as for the layperson also. Now, previously, Bayesian statistics was very, very complicated and it was difficult to do it even with the use of computers. But with the advancement in the statistical computing, the power of the devices have really improved and the modern tools are very, very powerful in doing the Bayesian stats. So it has become a more practical method to apply these in our clinical research. These technological processes support the increased use of Bayesian statistics in medical studies. So before you go into the details of what exactly is Bayesian, we need to understand what its basic framework. So what exactly is this Bayesian statistics? It is a method of statistical analysis that involves updating our beliefs or the probabilities about a particular hypothesis as new evidence or data comes in. As simple as that. It is based on Bayes' theorem, that is why the Bayesian statistics, which is a mathematical formula that describes how to revise my existing prediction or theory in the light of a new information. That's exactly what all research is about. So Bayesian theorem explained over here. The fundamental equation of the Bayesian statistics is the Bayesian theorem. This is the Bayesian theorem where the P hypothesis with the new data, that is the posterior probability. This is called the posterior probability. It is the probability of the hypothesis which we are testing after we have considered the new data. This is the likelihood, that is the probability of observing the data if the hypothesis is true. This is called the prior, which is the initial belief about the hypothesis after seeing the new data. And finally, we have the probability of observing the data under all possible hypotheses, often considered a normalizing constant. But the overall fact is, this is something which we are actually not going to do. This will be done by the statistical programs which are there. This is just to get a basic concept that we have a new data, we had a prior hypothesis and likelihood, and based on that, we are changing our information, taking all this thing into account. How does it work? So we start with a prior. We begin with an initial belief about a hypothesis based on the existing knowledge that we have or the previous studies that have been done. Then we collect a new set of data or the research that is done. We gather new evidence, data relevant to our hypothesis. Then we compute the likelihood, calculate how likely this new data is assuming the hypothesis to be true. Next, we update to the posterior. Using this Bayes theorem that you have already seen, we update our prior probability with the new data, resulting in a new belief, which is the revised belief, which we call as the posterior probability. So let's look at an example with medical context. Keeping it very simple, you are studying a new drug to treat hypertension. Okay. Based on earlier studies, there is a 40% chance that I know this drug is going to be effective. This is what has been studied till now. So I do a new study, a clinical trial. Patients take the new drug and significant blood pressure reduction is seen. So what is the likelihood that this is because of the drug? There is a high probability of observing this data if the drug is indeed effective. Now, based on the posterior, using the Bayes theorem, we update our belief and the probability that the drug is effective increases, say, to 70%. So previously, my prior belief was the drug is 40% effective in reducing the blood pressure, but including my new data and putting it in the analysis, I now find that I can say with 70% certainty that this drug is going to reduce the blood pressure. So another example with mortality rates. Say you collect the data, say for about 100 patients with a disease for 1 year, and you find that 30 patients die. So you estimate the true mortality rate in the population. That's your objective, trying to find out if this population is representative of the whole population, what would be the probable mortality rate. So this is what it looks like. So 0.3 is the mortality rate. So this, what you see, is the probability distribution, which means that the mortality can lie anywhere between this to this, which is around 15% to 45%. However, most of the chance that there is a mortality of 25 to 35% will be seen in around 90% of the cases. So you can say with 90% certainty that the mortality rate in the population would be somewhere between 25 to 35%. So what is the clinical interpretation? Most likely the mortality is around 30% based on the median of the posterior distribution. The uncertainty range that you saw, that is 95% confidence that the true mortality rate lies between that range that we saw, the 15 to 45. However, the probability between 25 to 35, by calculating the area under the curve in that area, we quantify the likelihood of the mortality within that limit. So why this matters to the clinician? It matters because the posterior distribution doesn't just give a single estimate, but shows the range and the likelihood of all possible mortality rates. This helps in appreciating the degree of certainty about the mortality rate. With this data that I have, it is extremely unlikely for me to say that the mortality rate in this particular disease is going to be 90%, right? So this makes my job a lot easier because with frequentist approach, it can be 90%. I cannot say with certainty that it will not be 90%. But with this, I can say with quite certainty that the mortality rate in this particular disease is somewhere between 15% to 45%. So knowing the probability that the mortality rate falls within a specific range helps us in the risk assessment and patient counseling, which is very important. For example, if there is a high probability that the mortality rate is above a certain threshold, the clinician will be more aggressive. If this disease had a very high, if in this we saw the highest was 45, if say it was to the range of 90, so I can counsel accordingly and make my interventions more aggressive. So the advantage of Bayesian analysis is that it provides intuitive and direct probability statements, unlike the traditionals where we say that there is a 95% probability that the true mortality rate is between X and Y%, which is more straightforward for the decision. So the fundamental difference between Bayesian and the frequentist statistics, this we need to really understand. I will go very slow with this. First is a philosophical foundation of the two things. Frequentist approach views probability as a long-run frequency of events occurring in repeated trials. So basically whatever you see, the confidence intervals, the p-values, everything is for if the trial is repeated infinite number of times. Focuses on the probability of observing the data given a specific hypothesis. It says that what is the probability that this particular data I am going to get, but my hypothesis is fixed. I cannot change my hypothesis. If the null hypothesis is true, what is the probability of obtaining data as extreme as what we have observed? You will get more understanding of this as we go further. This is the fundamental question of frequentist research. If the null hypothesis is true, what is the probability of obtaining the data? Say for example, I'm looking at an intervention in ICU and I find that the odds ratio after this intervention is 0.66. So this is the fundamental question. What is the probability that this 0.66 can be observed? If that probability is low, that is p-value is less than 0.05, which means the probability is less than 5%, I say that this is a significant improvement with the intervention. I'm going very slow so that the concepts are easily understood. However, in the Bayesian stat, considers probability as a degree of belief or certainty about a hypothesis. It focuses on the probability of the hypothesis given the observed data. Here the understanding is a little different. It looks at the probability that the hypothesis can change based on my observed data rather than my hypothesis being similar, and I am looking at the probability of the result being different, which is there in the frequentist approach. And finally, it updates from the prior belief, which means that it doesn't give us a clear-cut definition that like significant, insignificant. No, it gives us a change in the percentage of probability of what could be this event. In the frequentist approach, probability is objective and based on the expected frequency of outcomes in infinite repetitions of an experiment. does not make probability statements about the hypothesis or the parameters. In Bayesian, probability is subjective and represents the confidence or the belief in an hypothesis. It makes direct probability statements about an hypothesis and the parameters. Approach to the statistical inferences. In frequentist, it uses null hypothesis and significant testing. Relies on p-values and confidence intervals. Prioritizing avoiding type 1 error, that is false positive. In Bayesian, updates the prior probability with the new data. Produces a posterior probability distribution reflecting the updated beliefs. Focuses on progressively reducing the uncertainty. The role of prior information. In the frequentist, it doesn't really incorporate any prior information other than the sample size calculation. The inference is based solely on the data of the current study. Bayesian requires a prior, and the prior can be based on previous study, expert opinion, or can be non-informative or little information as well. Use of the probability distribution. Both approach use a probability distribution but interpret them differently. In the frequentist, the confidence interval, the 95% confidence interval means that if the experiment was repeated many times, the 95% of the calculated intervals would contain the true parameter value. Does not indicate the probability that the true parameter lies within the specific interval in a single study. In Bayesian, there is something called the credible interval. So the 95% credible interval means that the true parameter will lie 95% of the time within this interval. So dependence on study design and intention, frequent is very much dependent on it because the inference are based on strict adherence to the study design, the sample size and primary outcome. Deviation from the original plan can invalidate the results. P-value confidence interval are influenced by investigators' intentions and hypothetical repetitions. In Bayesian, inference depends only on the observed value and the prior distribution, nothing else. The likelihood principle states that all the information needed for the inference is contained in the likelihood function derived from the data. Study design intentions such as sample size, stopping rules do not really affect the posterior probability. Flexibility and adaptability. Frequentist is definitely not flexible based on the prior information. Interim analysis and modification complicates the interpretation of results. In Bayesian, it is more flexible. You can update your beliefs, naturally accommodates interim analysis and adaptive design. Handling of the uncertainty. In the frequentist approach, provides indirect information about parameters through p-values and confidence intervals. It does not quantify the probability of hypothesis being true. In Bayesian, that directly quantifies the uncertainty about the parameters and their hypothesis and produces a full probability distribution, that is a posterior reflecting current knowledge and the uncertainty. The philosophical debate. The frequentists argue that the incorporating prior belief induces subjectivity and the statistical analysis could be objective and based on solely on data. However, Bayesian contend that all analysis involves some kind of subjectivity because there is a subjectivity when we do sample size calculation, when we do interim analysis, and the formal incorporation of the prior information leads to more coherent and informative conclusions. In the implications for medical research, in the frequentist approach, the traditional clinical trials often use this approach. Results may be less intuitive and misinterpretation of the p-values and confidence interval are very common among clinicians. In Bayesian method, it aligns more closely with our clinical understanding. We don't really understand p-values, confidence interval, but we do understand the probability that this patient is going to die. That is common to us and it can provide more intuitive interpretation such as probability that a treatment is going to work. Increasingly feasible with advancement in the computational power. Now that we know what is the difference between the two stats, let's see what is this prior. Now, there are a lot of controversy associated with the prior because the main concern is that people think it is subjective. Some researchers worry that incorporating prior beliefs into Bayesian introduces some amount of subjectivity. Different investigators might have biases or perspectives leading to disagreements on what exactly is the prior should be for this hypothesis. The importance of the context is, in reality, data is always interpreted in a broader context. Journals often include expert editorials and discussions to help interpret new studies. If we did not need any discussion and we just needed to present our stats and results, then we would not have a discussion section in our journals. Despite the results being obvious, the statistical significance and the p-values being obviously reported in the result section, we still write a discussion section where we tell the interpretation of various findings that we have in our trials. So the need for that arises because all stats need to be interpreted. So there is some amount of subjectivity definitely there. And uh, if you look at the big journals like Lancet, they use a term that is research in context panel in their papers that are published, that aligns with the Bayesian approach, which considers the prior evidence, the new findings of this study, and what should be the overall implication of this particular study in the overall evidence that we know. So the role of prior in data interpretation is important because it helps in representing the existing degree of belief in that hypothesis before any new data is considered. The main challenge is specifying priors quantitatively in a valid, reproducible way that accurately reflects the prior information. This is important. We all have some kind of a bias for any kind of a hypothesis, but how do we quantify it in a valid and reproducible way? That is the point we need to discuss. So the purpose of specifying priors is to reflect the clinical beliefs. The goal is to capture the plausible and defensible degree of belief among the clinical community about a given hypothesis. Prior should represent the initial uncertainty or the confidence in a particular hypothesis. The types of prior. The most common one is the neutral prior, which is centered on the neutral effect, that is no difference with wide variance to reflect uncertainty. It is common in clinical trials to mirror the state of equipoise that justifies conducting the trial, of course. You can also have non-informative trials, which is extremely flat. So since you have no information, your center is there somewhere around the null effect, but the uncertainty is quite broad. So you have flat curves. It assumes all possible values as a parameter of equal likelihood. In theory, posterior distribution depends entirely on the new data, not on the prior. The challenges, though, is that in practice, not all parameter values are equally plausible. For example, extremely large effects are less likely. Defining truly non-informative priors may be difficult. So you cannot really say you can have non-informative priors. I can't just simply say that, say for example, ECMO in ARDS. I can't just say that it will never work in any patient. Obviously, it can work in some patient. So the extreme values may not be likely. So when to use, often not suitable for primary analysis, but can be helpful in sensitivity analysis to see how the data alone influences the results. In skeptical or pessimistic priors, in this, the belief is that there is no effect of the particular hypothesis. If the posterior prior still shows benefit, then the skeptical prior strengthens the confidence in the intervention's effectiveness. So, for example, I'm extremely pessimistic about ECMO in ARDS. So I have a pessimistic view that it is good in only 10% of the cases. But say a study happens and it shows that it was effective in 60% of the cases. So definitely it had a significantly large difference between what my prior was to what the posterior is. So from the prior to posterior, there will be a significant improvement which strengthens my uncertainty about the intervention. Constructing priors based on the previous data. So how do we make the priors? You look at the evidence that is available, the clinical trials, the meta-analysis. In previous study, how they differ from the correct word, the prior's influence can be reduced by increasing its variance, making it less certain. Borrowing historical data can be done using historical control groups, their event rates to inform the prior for a new study. So eliciting prior from stakeholders, gathering expert opinions, you can get the opinion of the clinicians, the researchers, the patients, the caregivers. Aggregate these beliefs to form a consensus prior. Benefit reflects a broader perspective and enhances the credibility of the prior distribution. So using a range of prior for sensitivity analysis, the purpose here is to specify different priors representing different levels of optimism and skepticism. Assesses how sensitivity the conclusions are to different prior beliefs. Say, for example, I can take three priors. I can take a very optimistic prior, a neutral prior, and a very pessimistic prior. I can see how this particular data affects the various priors. The outcome: if the results remain consistent across all the priors, even the most pessimistic prior I am finding benefit, then it definitely increases my confidence in the findings, which means that I can say very certain way that definitely this particular intervention is doing something good. So what are priors? Priors are the probability distributions representing our initial beliefs about a parameter. Example, a treatment effect before considering the new data. Why are they important? They allow us formal incorporating the existing knowledge or expert opinion into our statistical analysis. It helps to quantify the uncertainty and the influence on the posterior distribution. Balances the objectivity with subjectivity. While priors introduce an element of subjectivity, they reflect the reality of the clinical interpretation and is never entirely objective. The transparency and careful justification of the prior helps in mitigating concerns about its objectivity. How do we apply this concept in practice? When you are designing a study, consider what is already known about the hypothesis. We must have some data. Now, decide on an appropriate prior that reflects the knowledge and the uncertainty around it. Document and justify the choice of prior in your study protocol. During the data analysis, use the prior to compute the posterior distribution using the Bayes theorem. Perform sensitivity analysis with different priors to assess how robust the results are to changes in the prior assumption. Interpret the results. Acknowledge how the prior influenced the findings. If the posterior conclusions are consistent across all the priors, as I said, optimistic, pessimistic, neutral, the confidence in the result is definitively increased. This is a very important diagram. I will go very slow. Please try to understand. So if you look at the top panel over here, this is the null hypothesis. This is the frequentist distribution. In the null hypothesis, this is the point where we decide that beyond this, there is negative effect. Before this, there is positive effect. Say, for example, we are looking at the odds ratio for a particular intervention on mortality. So if it is less, then that intervention is improving the survival. If it is beyond that, it is increasing the survival. And this red line is the point of null effect. We did the study and we found that the odds ratio is 0.66. So it is around here. So this distribution that you see is called the sampling distribution under the null hypothesis. What we need to understand is when we do this particular distribution, this is exactly how we get our p-values. So what we are trying to do with the p-value, we are trying to predict what is the probability that we get this particular result, that is 0.66, considering that my null hypothesis is true, which means that there is no actual difference of using this intervention. So if the probability of this particular intervention of happening, if the null hypothesis being true is extremely small, then only we accept that there is a true difference between the, or we say that it is statistically significant, which means that after doing the sample distribution, this particular area, this area that you see, this small area, this has to be less than 0.05. If it is less than 0.05, that is the probability of this particular result is less than 5%. When the null hypothesis is true, then probably this is not because of chance. There is a real difference between the things. This is how the frequentist approach is done by the p-value. However, this is not the scenario in the Bayesian statistics. In this, the distribution of the data is around the result that we have found, that is 0.66. This is the point around which the data is distributed, which means that what we in the Bayesian analysis is saying is that the odds ratio, 95% of the chance will lie between this graph only, this particular graph. 95% of the chance that the actual odds ratio is somewhere like this, which means that most likely this particular intervention is positive. It is extremely unlikely that it has got a negative effect or no effect. Now, this is what we find when we do not have a prior. Now, when we do have a prior, as you can see over here, that is, say it is a less informative prior. So this green line here represents the less informative prior. So the prior is somewhere around here. We see that there is no much effect, and the distribution is extremely large, which means we're extremely uncertain about our findings. So what we see over here is when the uncertainty is too large and the information is less, this is the posterior that we get by using the Bayes equation. This is my finding. This is my prior. So I get this red line. You see the red curve? That is the curve which is showing that this is the posterior. Now, if I have more information, so I have this prior, which I think is 1, that is no effect, and my distribution is this time much less. That means I have lot more information, which makes my posterior distribution more strong. So which was more uncertain before becomes more strong now because I have more information in my prior. So this is my prior, this is the data that I have collected. Based on that, I get a new posterior. So this new posterior is my new belief. Now, you look at this red shaded area. This red shaded area means this is the probability that this particular intervention is actually definitely benefiting and is positively impacting the outcome. This gray area is the area of uncertainty. This is the area where I cannot be very sure that my intervention is actually giving any positive. So the main difference between the two is the Bayesian analysis distributes around the collected data. However, the frequentist approach is more around the null hypothesis. So I am more concerned about the null hypothesis, but in the Bayesian, I am more concerned about the data that I have collected, which makes the interpretation lot more easier with Bayesian analysis. So for the case study, we look at ECMO in ARDS. So we already know the background of ECMO in ARDS. It's a life support treatment that oxygenates the blood outside the body and returns it to the lungs. In ARDS, my lungs are very bad, so I need this particular machine to make the oxygenation better in my body. Now, the EOLIA trial was done to look how this ECMO was going to impact severe ARDS. Say at 331 patients, and it was admitted early because by the time they had enrolled 249 patients, the interim analysis showed that there is no statistically significant difference between the two groups. So the frequentist results were this. The mortality rate in the conventional group was 46%, in the ECMO group was 35%. There is an 11% decrease in the mortality with ECMO. However, if you look at the statistical significance, the relative risk was 0.76 and the confidence interval ranged from 0.55 to 1.04, which means that it was not statistically significant. The interpretation was that the difference was not statistically significant, therefore the trial could not confirm that ECMO reduces mortality in severe ARDS. Now, this was the author's conclusion because there was no way they could say with those stats that ECMO is benefiting, even with 11% reduction in mortality. So they did a reanalysis. This time they did the reanalysis with the Bayesian approach. They employed multiple priors. They included non-informative prior, enthusiastic prior, skeptical prior, and based on the previous study prior, in the result they found high posterior probability of benefit across every prior, even the most pessimistic of priors. It strengthened the confidence in the effectiveness of early ECMO. So how do we interpret the posterior distribution in Bayesian stats? It helps us in extracting rich information. Once you have estimated the posterior distribution, it provides a valuable source of information about the parameter that you're studying, that is the effect of a particular intervention in the treatment. Distribution combines your prior beliefs with new data to provide an updated understanding. The central point of the posterior distribution is summarized using the posterior mean or the posterior median. The posterior mean is the average value that is considering all the possible parameter values weighed to that possibility. And posterior median is the 50% probability of that particular intervention. So for understanding credible intervals, the credible interval represents the range between the two true parameter value actually lies. So 95% credible interval means that there is a 95% probability that the true value lies within that range, given the data and the prior information. This is more intuitive than frequentist confidence interval, which does not really provide me with such a direct statement. It just says that if I did this particular experiment numerous times, then 95% of the times my result will be between these results. But this is totally different from the data being present between those two parameters. So comparing the credible and confidence interval, the credible interval directly reflects the probability of the parameter in question. Whereas the confidence indicates that if we repeat that study multiple times, that's a 95% chance that the calculated interval will constrain the true parameter value, which does not really tell us the probability of the specific interval from our study. Flexibility of the credible interval. While 95% credible intervals are common, Bayesian analysis can further do it up to 90 to 99% depending on the desirable confidence. The choice depends on how certain you want to be. And calculating the posterior of benefit or harm, the posterior distribution allows you to compute the probability of benefit, that is treatment effect is beneficial or the treatment effect is harm. So example is, if you are evaluating an odds ratio of less than 1 indicates benefit, and odds ratio of more than 1 indicates harm. You calculate the area under the posterior curve and above a specific threshold to find these probabilities. Say for example, in the last one you saw, the area under the curve was more, that is red was more, so probability of benefit is more with the intervention. Now region of practical equivalence, ROPE. It is a predefined range where effects are considered clinically insignificant or negligible. The purpose is it helps us in determining if the effect is not just statistically significant but also meaningful in practice. I can't just give a random range and tell the clinician to work. It must be within his clinical practice. The next is assessing the clinically relevant effects. Using the posterior distribution to estimate the probability that the true effect exceeds the minimal clinical important difference is very important here. It determines the likelihood that a treatment has a meaningful impact on the patient's outcome. I can clearly see in which range, what is the probability that my patient is going to get a clinical benefit. I'm not just giving a random range. I can exactly pinpoint the range and the probability. Futility, the probability that a treatment effect does not exceed the minimal clinical difference makes it totally futile. The probability that the effect lies within the ROPE suggests that no meaningful difference between the treatment can be seen. And these assessments help in deciding whether to continue with our research or use the treatment that is already, if the new treatment is an expensive one and it looks like equivalent, then probably we should not be continuing with it. But this type of statement is difficult to give with the frequentist approach. The next is unifying the interpretation of the posterior. All these probabilities and assessment come from the same posterior distribution. And the advantage is provides a comprehensive, cohesive way to interpret the data and make informed decisions. So everything that we have discussed in the posterior till now will come from the same graph. You don't have to do 10 statistical analysis or 10 other tests. It gives you a simple, realistic, practical answer to your research question. Your updated belief about the parameter after considering the new data and prior information is called the posterior distribution. The Bayesian version of confidence interval directly states the probability that the true value lies within that certain range. Like we saw in the previous value, we can say with certainty that the mortality rate is somewhere between 15 to 45. Rho, it is a range of values considered too small to have clinical importance, helping us in focusing in meaningful outcome when the variance is too high. We can both calculate the benefit as well as harm from the posterior distribution by the odds ratio. How do we apply it clinically? The Bayesian approach allows clinicians to make probability-based decisions that align with the clinical reasoning. How do we interpret? Instead of just knowing whether the result is statistically significant, you understand the probability that a treatment will have a meaningful effect. This is very different from statistically significant. I can say that ARDS statistically shows no difference with ECMO, but with the Bayesian analysis, I'm clearly saying there is 95% probability that ECMO is going to benefit this particular patient. This aids in weighing the benefit and risk when considering a patient care options. If I can clearly tell this to the relatives and to my team, then we can make a more informed decision about whether we should be spending on the patient, allocating our resources there or not, plan our management, the aggressiveness, the futility, everything can be decided. So drawing conclusions from the Bayesian analysis, flexibility. Bayesian method offers flexibility in interpreting data which can be both advantageous as well as challenging. Unlike the frequentist method, they use a fixed p-value of p 0.05. Bayesian does not really have anything which we can say cut off. It just changes your posterior. Incorporating the clinical context. Researchers must incorporate the clinical context into their analysis before drawing conclusions. This means considering factors like the severity of the disease, the available treatments, that is the cost, as well as patient's preference. Posterior probability and practice changes. Since there are no fixed thresholds, no arbitrary p values, to declare that Bayesian analysis is going to change practice is a little difficult. So the posterior probability reflects on the updated belief and its risk benefits. So the context specific interpretation is important. It requires the posterior probability to interpret it based on every individual patient's individual situation. In disease with few treatment, a low posterior probability might be acceptable for a new low cost treatment. Conversely, an expensive and risky treatment for a high posterior probability may not be necessary. So you can interpret these based on the context. However, if you compare the two, you will probably find that the risky and expensive method is statistically better, but that doesn't mean you start offering it to the patients. So this gives you a clear context that this is the probability of getting benefit with this. This is the probability of getting benefit with the expensive treatment. So between the two treatment, which we can choose. Options are very clear. So coming to the EOLIA try again. The Bayesian analysis showed 96% probability that the ECMO reduces mortality, which is very good. Now, how do we interpret this? We interpret this based on the complexity and the cost. ECMO is a very complex procedure. It is invasive. It is costly. So you need to keep all the stakeholders. You need to inform them, the patient, the caregivers. They may prioritize survival. So they, despite the cost and the invasiveness, they may like to take the risk. The clinician, he must or she must balance the benefits against potential harm and the resource usage. Say, for example, I just have a one ECMO machine. I have two patients. How do I allocate the machine? So obviously, all the relatives will want their patient to be on ECMO. So now I have got a percentage. I have got interpretation and health administrators. They will look at the cost effectiveness, allocation of their limited resources. So the key question here is the 96% probability of survival sufficient enough to widespreadly use ECMO in severe ARDS? Because as we see, it is definitely complex, it is definitely invasive, and it's definitely costly. And different stakeholders may answer this question differently. So you must look at your own priorities, own concerns, own understanding before you use these posterior values for your clinical practice. So how do you report? Empowering the stakeholders by directly reporting these priors and the possible probabilities. All parties can now assess whether the evidence meets the criteria for changing practice. For example, this 96% is clearly available. It can be communicated to everyone. It is not like a study was done and it was found to be statistically significant, or no one can understand anything out of it. But a 96% benefit is understandable even to the layperson. So all the persons involved, the clinician, the patient and the relatives, the stakeholders, the hospital management, everyone is able to understand exactly what is at stake. So then we can change our practice or look into it. So it's a very transparent way of individualized decision making. So how do we do our decision making? The decision theory in Bayesian tool that helps determine the best action based on available data and various factors. It combines information from multiple endpoints such as the patient outcome, that is survival rate, quality of life, the cost involved, the financial implications, the patient priorities, that is preferences and values, calculating the value of intervention. The goal is to compute an overall measure of value for each treatment option, and the maximum expected value indicates the optimal intervention. So the implication for clinical practice. So we can tailor our decision. Decision is not based on rigid thresholds, but to tailor to specific clinical scenarios. Clinician can now make more nuanced choices that align the patient's need and the resources availability. You can collaborate, encourage collaboration among clinicians, patient caregivers, health economists, policymakers. So we can have more patient-centered care by considering the patient's preference and value. Bayesian analysis supports shared decision making. So this is the information which is very easy and easily understood by everyone. So the advantages of Bayesian conclusion is that it is flexible. It is comprehensive analysis that it integrates various type of data and outcomes. It enhances the interpretation. The probability is something which is directly meaningful for us. And challenges to consider for Bayesian analysis, it is little complex in terms of its calculations because it requires and takes into consider multiple factors. We don't have any standardized cutoff for values. It is definitely resource intensive because the Bayesian analysis may require more data and computational resource. So this is a very classical example. You see as the number of patient increases here, 50, 100, 200, rather in each group. So 100, 200 and 400. So as the number of patient has increased, you can see here the posterior probability is becoming more and more slim. So I'm getting more and more certain about what is my outcome likely to be. My odds ratio from 63% is 98%. So I'm 98% certain that this is my outcome going to be. So this is a very important understanding about the Bayesian stats. As you gain more and more data, you become more and more certain about, and you can keep this as a cutoff, say 98%, 99%. Beyond that, you probably don't need to do a research on that particular topic. So the take home message is Bayesian analysis updates prior beliefs with data while frequentists rely on fixed hypotheses and p-values. Bayesian method allow real-time updating and adapting trial design, enabling earlier decision based on accumulated data. Borrowing data between subgroups increases precision and effective sample size in the Bayesian models. Credible interval provides direct probability of the true effect, while confidence interval just shows the range for repeated trials. And finally, Bayesian posterior probability supports more informed, flexible decision making in clinical practice, especially with heterogeneous population. Thank you for your patience.